All right, now we perhaps saved the best for last, only you can tell us that, but I'm very happy to introduce you to Dr. Randall Curtis. He is an MD and he has a master's in public health. He's a professor of pulmonary and critical care medicine. He's the Bruce Montgomery American Lung Associated Endowed Chair. Endowed Chair means they think you did such a good job, they put a giant pile of money aside for you and you get the little dividends that come off of that. He's the director of the UW Palliative Center of Excellence and a section head of pulmonary and critical care at Harborview. Here he is skiing downhill with his helper who's obviously holding him up. His daughter Alice. Is that you, Alice? Excellent. Adjunct professor, Department of Bioethics. That seems like that would be appropriate. And Humanities. In the Department of Biobehavioral Nursing and Health Systems. That's long. It's too long. I'm cutting that down. Okay. Clinical practice includes critical illnesses. And you can read all about them right there. Now here he is with his family, his beautiful wife and his daughter. He got his BA at Hampshire College in Amherst, which is actually a really beautiful part of the country. Got his MD degree from Johns Hopkins. He's a Robert Wood Johnson Clinical Scholar, which is really a distinguished award. And as I mentioned, he has an M.P.H. as a Master of Public Health in Epidemiology at the UW School of Public Medicine. So he's going to talk to us tonight about palliative care, and this is such an important topic that it's a great joy to have him come and be with us.
Thank you, Terry. Well, it's a real pleasure to be here. And I'm going to talk about palliative care, and I'm going to particularly focus on how we measure and improve communication about palliative and end-of-life care. Some of the research I'm going to show you is done by our research group, and that was funded primarily by the National Institute of Nursing Research, which is one of the institutes of the National Institutes of Health, and I have no financial conflicts of interest to disclose. So I'm going to try to address these questions for you. First, what is the problem with palliative end-of-life care? And specifically, I'm going to focus on communication. Communication about the kind of care that we want if we become too sick to speak for ourselves. I'm also going to ask the question of how we measure communication with the idea that if we can't measure it, it's hard to know whether or not we've improved it. I'll ask a question of whether we can teach communication. Some people have argued that it's an innate skill and difficult to teach, and I'll try to convince you that that's not true. And finish up by talking about some future directions. First, let me start with a definition of palliative care. This is a definition from the Center to Advance Palliative Care, or CAPC. Palliative care is specialized care for people with serious illness, focused on providing patients with relief from symptoms and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and their family, and is provided by a team who work with the patient's other doctors and providers to provide an extra layer of support. Palliative care is appropriate at any age and at any stage in a serious illness, and can be provided together with curative care, curative treatment. So this definition tries to make the case strenuously that palliative care is not the same thing as end-of-life care, but in fact much broader and should start earlier. And I like to think of it like this, that palliative care encompasses end-of-life care, but is much broader, is focused on improving quality of life for anyone with a serious illness. End-of-life care is care specifically for patients who are actively dying or thinking about the kind of care we might want when we're actively dying. And then hospice care is a very important subset of end-of-life care. It's a specific model for the delivery of end-of-life care through hospice services. I think these definitions are important because when we equate palliative care with end-of-life care, we miss important opportunities to introduce the principles of palliative care earlier in a serious illness than in the phases of active dying. Death panels was a concept brought up in a political context, in a political debate, to try to make a point and equating palliative care and talking about end-of-life care with death panels. But in fact, despite that political rhetoric, most Americans don't view talking about end-of-life care or palliative care as similar to or equal to death panels. This was a survey that was done by the Regents Foundation, and they asked Americans what they thought, whether they thought it was important that patients and families be educated about the palliative care options that are available to them. 97% of Americans agreed with that statement. They also asked, how important is it that palliative care be a top priority for the healthcare system? 96% of Americans thought that was important. So this is a topic that most Americans, in fact, do want to have as part of the healthcare system and do want to talk about. I also like to make the distinction between primary palliative care and specialty palliative care. Palliative care cannot be relegated entirely to specialists in palliative care. If we're really going to do a good job of caring for people with serious illness, then we need to train all clinicians who care for patients with serious illness in the basic tenets and the concepts of primary palliative care. Specialty palliative care is an important component of palliative care, care provided by palliative care specialists. But if palliative care specialists are the only ones who do this, then we're also going to miss important opportunities to provide high-quality palliative care to patients and their families. Well, how are we doing? These are data that were published just earlier this month by Joan Tino and her colleagues in the Journal of the American Medical Association, or JAMA, where she looked at trends in the provision of end-of-life care to Medicare beneficiaries. So these are people over the age of 65. And if you look at the yellow line there, those are the individuals who received hospice care at the time of death. And between 2000 and 2009, that went up significantly from 20% to over 40%, which is great. However, if you look at the red line there, those are the patients who got hospice care only in the last 3 days of life. Really not the ideal time to bring in hospice care. And in fact, that was going up and represented a significant proportion of the increase in the use of hospice. And the blue line shows that the number of patients, or the proportion of patients who received acute care, that is care in a hospital, which most Americans tell us they would not want at the time of death, that went up in the last 90 days prior to death. And the intensive care unit, the most aggressive or intensive kind of medical care that we can provide in a hospital, the proportion who got that in the last 30 days also went up. So despite our efforts of improving palliative care, I think we've made some advances, and I'll talk more about that, but what we see is the intensity of care that patients and families are receiving and undergoing at the end of life is actually increasing. Now, this is a headline from an article in the New England Journal of Medicine that really made an enormous impact on our health care and medical care. It was a randomized controlled trial, meaning that patients were randomized to either receive palliative care or to receive usual care. These were patients who had metastatic non-small cell lung cancer, so a kind of lung cancer that cannot be cured. What they found is, in this study, I should say, the study took place at the Massachusetts General Hospital, a place where they deliver good quality care to all their patients. What they found is the patients that got randomized to palliative care, as well as the usual care that all patients get, had higher quality of life using a standardized scale to measure quality of life compared to the patients that got standard care without getting early palliative care. They also found that the group that were randomized to early palliative care had fewer symptoms. This slide shows particularly the reduction in depressive symptoms as measured by a score called the HADS-D, which measures depression. There was a trend towards improvement in anxiety that wasn't quite statistically significant. And they also had reduced levels of anxiety compared to the usual care group. And then what came as a big surprise and what made the biggest impact, I think, was the fact that the patients that got randomized to palliative care survived longer than the patients who got randomized to usual care. And in fact, this improvement in survival is better than the improvement that any of the chemotherapy agents provide for patients with this particular kind of cancer. Now, why would patients randomized to palliative care survive longer? We don't really know the answer to that question, but we do know that those that got randomized to palliative care had better control of symptoms, and we know that symptoms can shorten life. We also know that patients who are randomized to palliative care were less likely to have toxic chemotherapy in the final week of life. And in fact, our well-meaning efforts to prolong patients' lives in some illnesses may actually shorten patients' lives. And palliative care, talking to patients about the kind of care they want, whether they really want to receive a potentially toxic chemotherapy agent or not, may have significant benefit in terms of how long patients live. Well, data like this and the general trends in the interest in this area have resulted in dramatic growth in palliative care programs. And this slide shows the number of hospitals in the US that have a palliative care program, showing really significant increases between 2000 and 2010, from somewhere around 40% of hospitals to almost 80% of hospitals having a palliative care program. Really a rapid growth as a result of some of the research that's been done showing the benefit of palliative care. At the same time, there's been research to show that palliative care, in addition to improving quality of life and improving symptoms, can actually reduce costs of care at the end of life. And in fact, higher costs of care at the end of life are associated with a lower quality of dying. And this is data that demonstrates that fact, that as the costs of care increase along the horizontal axis, the quality of dying, as rated by patients' families, actually decreases. So I've hopefully convinced you that palliative care is a good thing, that an important part of palliative care is talking with patients and their families about the kind of care they want at the end of life, particularly at a time when they can't speak for themselves. Well, who should bring up this topic? If you ask patients, they say doctors should bring it up. If you ask doctors, they say patients should bring it up. Well, there's a problem there, right? And in fact, this has been a problem that's been difficult for us to solve. So what can patients do? What can any of us do to ensure that we receive the kind of care that we want? Well, one approach has been advanced directives, the idea that we fill out advanced directives, trying to direct the care that we will receive. Advanced directives come in two primary forms: the living will, where you try to put on a piece of paper the kind of care that you want and limitations that you may want in the care that you receive. And then durable power of attorney for health care, where you specify who you would want to make decisions for you if you were not able to make decisions for yourself. Both of these are very important and useful, and I'll talk a little bit more about them. But I think perhaps an even more important advance than advanced directives is the concept of advanced care planning, a broader concept that may include advanced directives, but is really focused on communication with families, as well as doctors and other clinicians, about the goals, values, and preferences that patients may have. Well, what are the data to support either advanced directives or advanced care planning? And in fact, there are a number of studies looking at advanced directives, and I'll just show you one, a study that was done in the late 1980s, published in the early 1992s, in early 1990s, where patients were randomized to either usual care or a physician offer of advanced directives. They had 104 patients offered advanced directives. Most of them preferred some kind of limitation in the kind of life support they got at the end of life, and 2/3 completed advanced directives. Importantly, in this study, there was no communication with the family. This was just between the doctor and the patient. And this study was utterly negative. Offering advanced directives had absolutely no impact on the kind of care that patients received. This is only one, as I said, of a number of studies that really brought about a a lot of cynicism and skepticism about the value of advanced directives. Well, why might advanced directives fail? One reason is that it's very difficult ahead of time for most people to predict what kinds of treatment decisions might need to be made and to document those on paper. Predicting what kind of care we would want in the future is also limited by adaptation to disability. People may say, well, I would never want to live in a wheelchair, develop an illness that puts them in a wheelchair and find that, in fact, their quality of life is quite good. There may also be changes in medical, emotional, or social context between the time of completing advanced directive and a time when decisions need to be made. And patients also often want their family's circumstances and preferences taken into account, and sometimes that can be hard to summarize clearly in an advanced directive. There was this real sense of skepticism about this area until more recently, when there have been some studies to show that, in fact, if we think more broadly about advanced care planning, it does make a difference. This was data from a study done in Australia with patients who were hospitalized and over age 80, randomized to either advanced care planning by a trained facilitator or usual care. In this study, over 80% received advanced care planning, which is what was supposed to happen. A little over half completed in advanced directives. The facilitators were trained using a method called respecting patients' choices. Was done in collaboration with their physician, so the physician was there for the beginning of the session to support it, but then didn't stay for the whole time. Importantly, families were present in 72% of the time, so the families were able to be part of the discussion, hear what patients said and what their preferences were. And this was fairly time-consuming. These sessions took a median of about 60 minutes. This study showed significant differences in the care patients received at the end of life. The proportion that died in the intensive care unit, that most aggressive place in the hospital, was 0% in those that were randomized to advanced care planning, compared to 14% in the control group. They had significant reductions in psychological symptoms in family members, including post-traumatic stress disorder, depression, and anxiety. And family members were much more satisfied with the death, the patient's death, as well as with the care the patient received in the group that were randomized to advanced care planning. So why would it be that advanced directives failed and advanced care planning succeeds? Advanced directives are focused on a document, a static piece of paper that may be difficult to adapt to real-life situations, and it's often done, at least previously in the 1980s and 1990s when this was first developed, was done without discussing the broader ideas of individuals' goals and values. Advanced care planning offers a discussion of those contextual goals and values and really does a much better job of preparing patients and their families to address actual situations that may arise. So I actually think advanced directives are very important, but they're important in the context of advanced care planning, namely having a discussion about the kinds of care people want, about their goals and their values. So most of this discussion is done by physicians. How well do physicians do? Well, I'll tell you there's room for improvement. This is studies that were done audio taping 87 different patient-physician discussions about advanced care planning and whether patients wanted CPR or whether they wanted to have a do not resuscitate order. These physicians were chosen for being experts. So these investigators went out and they tried to find experts at talking to patients about end-of-life care. They found that the doctors spent 73% of the time talking and only 27% of the time listening. They also found that the doctors rarely initiated discussions about the values and goals, less than a third of the time, and even less often did they explore the reasons behind the preferences or ask patients to define what was important to them about their quality of life. So here's an example. This doctor is seeing a patient, and the doctor says, well, now that you have it, you can stop worrying about getting it. Probably not the best communication. So we were very interested in asking patients and their families what was important to them about physician skill at providing end-of-life care. We involved a number of patients with different life-limiting illnesses, including emphysema or COPD, cancer and AIDS, as well as family members, and also physicians, nurses, and social workers. We developed this conceptual model for physician skill at the end-of-life care that included 5 domains: communication, cognitive skills, affective skills or emotional skills, patient-centered values, and patient-centered systems. And I'm going to focus for today on communication skills. And specifically, what patients said was important to them was that we listen. I've already told you that doctors spend most of the time talking and very little time listening, and in fact, patients say that's one of the most important features. They also told us that they wanted us to encourage questions from the patient. They wanted us to talk with patients in an honest and straightforward way about prognosis and diagnosis and so forth. But to do that, particularly around bad news, to do that in a sensitive way, to demonstrate that we cared about what happened to them and about their lives. They wanted doctors to be willing to talk about dying, but to be sensitive to when patients were ready to talk about dying and end-of-life care. We also identified a number of barriers from both patients' and physicians' perspectives to talking about end-of-life care, and this is a study of patients with advanced emphysema or COPD. These patients had quite advanced disease, were on oxygen, and yet only less than a third of them reported ever discussing end-of-life care with their physician. They identified a lot of barriers, and yet only 2 barriers were identified by more than 50% of patients. So a lot of these barriers are very specific to individuals. We also identified barriers from physicians, and again, only 1 barrier was applicable to more than 50% of physicians, suggesting that what we need to do is figure out what the individual barriers are for individual patients and their physicians, and then develop solutions to those barriers. As an example, the 3 most common barriers endorsed by patients, the most common was, I would rather concentrate on staying alive than talk about death. This is not something that most people are comfortable talking about. I'm not sure which physician will be taking care of me if I get very sick, so I don't know who to talk to. An increasing problem in our increasingly fragmented healthcare system. And I don't know what kind of care I want if I get very sick, so I don't really know what to talk about. A fairly common misconception that you have to know exactly what kind of care you want to have these kinds of discussions. We were also interested in the interplay between wanting to support hope and wanting to provide truthful prognostic information. Physicians report this as one of the major barriers, that they don't want to talk about bad news, they don't want to talk about prognosis for fear of destroying patients' hope. And for that reason, it's one of the big reasons that they don't talk about it. If you read experts, they say, well, we should redirect patients' hope. We should take patients who hope for a cure and have them hope for something else. And there may be some value to that, but in fact, many patients find that upsetting. They don't want to hope for something else. They want to hope for a cure. And so we were interested, again, in understanding from patients' perspective how they held these 2 ideas, or what the interaction was between hope and prognostic information. And we found that patients endorsed one of 4 different models for the interaction between these things. One model we called back and forth, where patients told us, I can either think about my prognosis or I can think about hope, and I can't do both at the same time. A second model was one that we depicted with the scales, where people said, well, I try not to get too hopeful because that's unrealistic, but I don't want to dwell too much on prognosis because then I get depressed. A fourth model we depicted with the yin and the yang, where some patients said, there's no conflict between these 2 things. I can have my hopes and hear honest, straightforward information about my prognosis. And in fact, information about my prognosis helps me. It helps my hopes. It helps me make sure I'm hoping for realistic things. And then, in fact, some people did endorse what the experts said, where they used to hope for a cure. Now they're hoping for other things, quality of life, time with family, and so forth. People talked about holding different models or having different models apply to them in different time periods. But one of the things that was interesting was the way they wanted doctors to talk to them about end-of-life care differed for these different models. And for the top two models, patients tended to prefer an indirect approach to talking about prognosis. So for patients with disease like yours, this is what often happens, not making it directly about the person. People who endorsed the lower two models actually wanted a direct discussion about them, their prognosis, their quality of life, and how this illness may affect them. And understanding this helps us teach doctors how to have these conversations in a way that's more helpful for individuals. So that's a little bit of background about palliative care and about talking about end-of-life care. And I'd like to spend a few minutes talking about how we measure communication, because that's an important step to figuring out whether we can improve it. And here's an example: a doctor saying to a woman in the waiting room, if it's any consolation, toward the end he was as high as a kite. Excellent symptom control, perhaps, but not so good on the communication. So there are a couple of different ways to think about measuring communication. One is to actually audio tape communication or videotape it and have it assessed by experts or scored with quantitative scoring tools. And this is actually a very useful technique, fairly time intensive, but it can be very useful. Another method is to assess the patient's experience or understanding either through surveys that they fill out or through interviews, what we call semi-structured interviews, where patients can kind of talk about their story and their experience with communication. We've been using all of these, but we've been interested in particularly focusing on the surveys, because that's something that we could do in a much more scalable or feasible way on a large scale for large studies to try to figure out whether we can make a difference. We developed this one particular scale that we call quality of communication that has 13 different specific questions, tested it in patients with life-limiting illnesses, and found that in fact it seems to work fairly well. It has two subscales. One's general communication skills, and one is more specific to end-of-life care. And it meets some of the criteria that we expect of these kinds of scales. The items tend to track together, which you would want. We don't have a gold standard that we can compare it to, so we use something called construct validation, making sure it tracks with related constructs. And both subscales are significantly correlated with overall ratings of communication as well as overall ratings of care, the number of times a doctor has talked about end-of-life care with the patient, as well as the doctor's knowledge of the patient's preferences for end-of-life care, giving us some evidence that this scale measures what we think it measures. We were also interested in asking the question, now we were doing a study of trainees. These are residents in internal medicine. And we wanted to see what the relationship was between their ratings of their own communication skills and the patients who they care for, their ratings of their communication skills. And so we plotted that on a graph, and here's the results. Absolutely no relationship. No relationship whatsoever. So self-assessment may have some value, but it doesn't predict what patients experience of this communication, and should not be used, in my view, as a measure of whether or not we've made things better. So can we teach this? Can we teach people to do this better, or is this an innate skill? And in fact, there is some evidence that we can teach people to do this. Here's a patient in a doctor's office, and the doctor's saying, there's no easy way I can tell you this, so I'm sending you to someone who can. I don't endorse this approach. I think that palliative care specialists have a very important role, but that all clinicians who care for patients with serious illness need to have some basic skills, and we need to teach them those basic skills. Can we do it? Yes. The answer is yes. And I'll show you a couple of examples to make that point. This was a study of 160 oncologists who were randomized to a skill-building course where they interacted with actors and actresses designed to play patients, got a chance to practice, got feedback, got a chance to do things again. Or they were randomized to some written feedback from experts who watched videotapes of them with their patients and gave them very specific and targeted advice about how they could improve their skills. There was also a group that got both and a group that got neither, so they could see what seemed to work. To assess whether or not communication skills got better, they videotaped these oncologists with 6 to 10 patients 3 months after, and they found that the skills building course resulted in significant improvements. Improvements in the use of focused and open questions, in expressions of empathy, and in appropriate responses to patients' cues or to what patients said. Interestingly, the written feedback had no effect whatsoever, suggesting that if we want that this is a skill like driving, if we want people to get better, we have to give them a chance to practice it. It's not enough to give them written feedback or to give them lectures. Tony Bach, who's also here at the University of Washington, did a similar kind of intervention, which he called UnkoTalk. This was a 4-day residential set workshop with oncology fellows, trainees learning to become oncologists. They had 115 fellows from 62 different institutions who took this course, and they were tested with standardized patient stations before and after the course, and found that they could teach people to acquire specific skills around delivering bad news and around transitions to palliative care. In these standardized patient sessions, they were asked to give a patient the diagnosis of cancer. Before the workshop, only 16% of these oncology trainees used the word cancer, and they got that up to 54% through the skills building course. This graph shows some of the areas that improved. These are the percent who didn't have a skill before the workshop, had the skill after the workshop, assessing the patient's permission, requesting permission to give bad news, which is an important part, using the word cancer, being silent for 10 seconds after the news, making an empathic statement after giving the news, asking for the patient's reaction, and then summarizing a follow-up plan. In each of these, they were able to teach a significant proportion of these trainees this skill through this workshop. We also recently finished a study of another way to try to improve communication for clinicians who take care of patients with COPD or emphysema. This was done at the VA here in Seattle. And in the intervention, we identified these patient-specific barriers that I told you about, as well as facilitators, patient-specific facilitators, for talking about end-of-life care, fed that back on a one-page information sheet to individual patients and their clinicians, as well as family members, and provided the clinicians with tips for how to overcome these barriers. And what we found is that we were able to increase communication about end-of-life care threefold, which sounds pretty good. In fact, it went from 11% to 30%, so still some room for improvement. But this relatively simple intervention increased the proportion talking about end-of-life care, and then it also increased the ratings of the quality of that communication. So there are ways to improve it. We have to figure out better ways to implement these training mechanisms to try to improve communication, but it's certainly possible to do it. So where do we go from here? Well, we have a number of ongoing studies. One of them is a randomized controlled trial of a communication facilitator in the intensive care unit. This is a nurse or social worker who's trained not to do the communication, but to help the ICU team meet the communication needs of individual patients' family members, using communication skills, mediation, trying to identify conflict and help resolving conflict, and also attachment theory as a way to adapt communication to specific individuals. And we're looking to see whether that improves families' psychological outcomes, particularly depression and PTSD, after a patient has a critical illness. And then we're doing a randomized trial of a skills-building workshop that's based on the UnkoTalk that Tony Bach developed, and we're doing that here with physicians as well as nurses in an interdisciplinary setting, using simulated patients and families so they can practice, and then we're measuring outcomes not based on whether they have the skills, but actually based on real patients and families' ratings of their communication. Another way that we're moving forward is that we have developed a new Palliative Care Center of Excellence that Terry mentioned in the introduction. This is a UW-wide and intended to serve as a regional resource in palliative care. The mission is to improve palliative care received by patients with serious illness and their families and to provide support for clinicians. We're also interested in developing new knowledge and educational and clinical resources to improve palliative care regionally, as well as nationally and globally. This is a picture of our website, and the URL is there, uwpalliativecarecenter.org. So how could you get involved if you're interested? If you're interested in palliative care, you can join as a Palliative Care Center of Excellence member to help develop or use the resources that we're developing. If you care for a patient with serious illness, we provide education in primary and specialist palliative care, as well as resources for patients and families. And we're also very interested in community input to make sure that we're meeting the needs of the community. We're planning a couple of community forums that you can find out about from our website in April, where we're looking for feedback from the community. So in summary then, what I've tried to cover is to make the case that palliative care is gaining momentum and that communication is a central component and has a central role to play in the delivery of high-quality palliative care. Measuring the quality of communication remains challenging, but I think we're making some progress. And the interventions can clearly improve the quality of clinician communication, but it does require practice, that we can't expect people to read about this and that may have them make that better, or we can't expect them to learn it in lectures. And then finally, we have developed a Palliative Care Center of Excellence to try to integrate and coordinate the excellence that we have across the system that currently exists in pockets to really try to bring this together in a unified and systematic approach to improve the care that patients and families receive. And with that, I'll stop and thank you very much for your attention.
Wow, that was really fabulous. We're going to have just a couple of questions that we could take, but I want to encourage you all to go home and have a conversation about this. If we can't initiate a conversation off of tonight's lecture, then we really are at a loss for words. And it's amazing, we don't know what is going to befall us in our lives. And you never know when this might be something that you wish you would talk to your family about. So I encourage you to use this as a springboard for conversation. So with that, let's take one or two questions if we might.
I'm curious to know what kind of training students here at the University of Washington in healthcare are receiving, whether doctors, nurses, in palliative care.
Yeah, it's a good question. And what I would say is that we have, like our clinical care, we have pockets of excellence. We have excellent instructors, we have excellent courses. We don't yet have a systematic way to have an integrated curriculum that cuts across the years of training in, for example, medical school, postgraduate training, and then once people are in practice, or for nurses and social workers and others. And I think that's one of the things the center is really trying to do, is to identify where we do have pockets of excellence and try to build on that and develop more of an integrated curriculum. There also is very little education that occurs in an interdisciplinary or interprofessional way. So doctors and nurses are expected to work together as a team, and social workers and others, but in fact they're not often educated as a team, and that also creates a real problem that we're trying to overcome.
There are about 8 or 9 of us here tonight that work as interpreters in various languages at the University of Washington Medical Center, and we encounter this with people of different cultures. I'm wondering, and it can be very challenging, and I'm wondering what studies have been done or what efforts there are made to address people that come from all over the globe here and at Harborview.
Yeah, this is a very important issue, and we have done some research on this. I think that research has backed up what you said, which is this can be very difficult to do across cultures and across languages, and that there are important and powerful differences in the care received across different cultures and racial and ethnic groups. And one of the problems I think that's most pressing is that some of those differences are due to different preferences about end-of-life care, that may vary a lot by culture and ethnicity, and those preferences should be honored and respected. Some of those differences are due to disparities, and that people don't get offered to have the same kinds of conversations, or doctors aren't as straightforward or direct when working in a cross-cultural setting. And we need to find ways to differentiate those that are based on preferences and should be honored and respected, and those are based on disparities, and we need to develop tools to overcome them.
Do you involve anthropologists in this?
We have involved anthropologists in this, and I think that some of the qualitative research that I showed was done with anthropologists as an important part of the team, and I think has added a lot to our understanding of what's happening and where the important areas for improvement are.
I'm going to cut us off here. If you have questions, please come up and talk to Dr. Curtis afterwards. But first of all, I want to thank our two fabulous speakers for joining us tonight. It was really wonderful.